Hello, I'm Mark Pegram. I'm a medical oncologist at the Stanford University School of Medicine and the Stanford Cancer Institute. I'm the Associate Director for Clinical Research there and a member of the Breast Oncology Program. Which patients should receive preoperative or neoadjuvant chemotherapy as opposed to, let's say, postoperative chemotherapy? And what are the benefits of such treatment? So the overarching goals of neoadjuvant therapy of any kind, whether it's chemotherapy or HER2-targeted therapy or even preoperative endocrine therapy, the overarching goals of all the preoperative approaches are to convert non-operable tumors into operable breast cancer. For example, some tumors are so large or have spread extensively to the regional lymph nodes that the probability that the surgeon could get all of the tumor out surgically with clear negative final surgical margins may be low probability to get it all at the time of diagnosis. So surgeons will take advantage of the opportunity to shrink the tumor preoperatively with systemic therapy like chemotherapy, to shrink the tumor to convert an otherwise inoperable tumor into an operable tumor that can achieve negative margins and truly get all of the visible cancer out of the patient. Another reason to consider neoadjuvant therapy is to increase the success and cosmetic outcome of breast conserving surgeries. We know, for example, that lumpectomy plus radiation is equivalent to mastectomy in terms of effectiveness of eradicating human primary breast cancer. So both of those are options, and yet breast conserving surgery maintains a good cosmetic outcome in most cases. And consequently, if the surgeon tells you that if they could just shrink the tumor somewhat, they might get a better cosmetic outcome, that would be another reason to consider preoperative systemic therapy like chemotherapy. Next, to reduce the extent of surgery required in the breast and in the axilla. It stands to reason that smaller tumors are simpler to remove than larger ones, and therefore the extent of surgery required to remove a smaller tumor that has been decreased in size by preoperative therapy, it's a simple concept that makes it easier on the surgeon, again, to achieve negative final margins, and it may obviate the need for extra treatment to the axillary lymph nodes, like axillary dissection or radiation to the axilla, etc. Next, giving preoperative systemic therapy like chemotherapy gives you a wonderful opportunity to observe the response to such chemotherapy. Whereas if you give it post-op, it's given empirically. You don't really know if it's working unless the patient lives a normal lifespan without any relapse of breast cancer. But to actually see the response can be very helpful, because then you can know, is the patient truly sensitive to chemo, or do they have a chemo-resistant tumor, for example? And that's another good reason to give preoperative therapy, so you can actually observe and measure the tumor size before and following chemotherapy treatment. Another fantastic opportunity with this pre-surgical approach to chemotherapy is it gives you an opportunity to look at how much residual disease is left behind after the chemo. Because in some patients, they can achieve complete pathologic response where the tumor disappears altogether. And that can be achievable in some cases with a pretty respectable frequency. And those patients obviously have the best prognosis. So being able to observe the extent and depth of treatment is very important. For example, it's been shown that patients who don't respond as well to preoperative chemotherapy may benefit from additional postoperative systemic treatments. For example, drugs like capecitabine, also called Xeloda is the brand name, can be given postoperatively in some patients who have residual disease following preoperative chemotherapy. And HER2 positive patients may benefit from the antibody drug conjugate called TDM1 postoperatively instead of just taking Herceptin and Perjeta for the rest of the year. It's been shown that taking this TDM1 drug is actually superior to Herceptin alone in patients that don't have a pathologic complete response to preoperative chemotherapy plus HER2 targeted therapy. Finally, neoadjuvant therapy is being used, importantly, as a research tool to assess molecular responses to new drugs. pharmacodynamics, and that means what impact is the drug having on its target in the patient. That can be measured when you get a biopsy before the treatment and a repeat sample of the tumor at the time of surgery. So you get pre and post-treatment samples that you can analyze in the laboratory. You can even measure intratumoral concentrations of experimental drugs to make sure that they penetrate into breast cancer well to have a therapeutic effect. So in summary, the general principles are to treat non-operable breast cancer to render it operable, increase the success and cosmetic outcome for breast conserving surgeries, reduce the need and extent of management of the axillary lymph nodes, to tailor postoperative therapies based on initial response to preoperative therapies, and for use in research as a research tool.